Okay, so very good afternoon all. Am I audible?
Yes, sir.
Yeah, thank you. So welcome for our today webinar. So which is based on the performance indicator in QAI accreditation standard for stock centers. So I welcome on behalf of QAI. My name is Manish Kumar. So before proceeding with the agenda, we can have a quick introduction about QAI, then our today's speaker, then we'll start with the agenda. And at the end, we'll have a QA accreditation process, which is taken care by my colleague Ms. Chandni. Then at the end, we take query and your doubt session. So this is the agenda for today webinar. So welcome all of you. So QI Quality and Accreditation Institute, this is India largest second largest accreditation body. So we also give accreditation as per the ISO standard along with the healthcare standard, which is developed by QI for the healthcare. So, Dr. Bhupender Kumar Rana is our founder and CEO. He's having over 25 years of experience in quality, standard development, accreditation, and patient safety. Former, he has been associated with NABH as a director and CEO in charge, the Body of Quality Council of India, where his visionary and leadership transformed the healthcare quality framework in the country. He is a vice chair of Mutual Recognition Arrangement MRA, Council of Asia Pacific Accreditation Corporation. He is founding member of International Academy of Quality and Safety, IAQS, member of Scientific Advisory Board, International Alliance of Patients, Organization IAPO, former board member and chairman of Accreditation Council of International Society for Quality in Healthcare, ISQA. He is international expert of World Health Organization, WHO, also is with the World Bank, Asian Development Bank, and the United Nations Framework Convention on Climate Change. So as I earlier mentioned, we are second largest accreditation body in medical or healthcare accreditation process, and we have a global recognition with this QAI, also ILEC and APEC. So QAI having a vision, values, and mission. So we having a vision to nurturing the largest global pool of organizations and people through quality improvement and accreditation framework. We are having some values. We are good listeners. We always seek continuous feedback from stakeholders to address their concern. We are competitive. We always we look for viable options to benefit users of our services. And KIS has transparency because whatever the policies are made available, they all are available on public domain on our website. We are innovative. We continuously evolve using co-design and co-creations. We are having a mission to conceive and deliver education, training, accreditation, and related program in partnership with various stakeholders using an approach of co-design and co-creations. So KI having a four verticals. First, was Center for Education and Training, under which we do offer various kind of training as per the ISO standard or other healthcare standard. Then we have CHSC, Center for Accreditation of Health and Social Care, under which we do offer accreditation for the healthcare service provider. Then CIA, Center for International Accreditation, formerly known as the Center for Laboratory Accreditation, under which we do offer accreditation as per the various ISO standard, whether it could be ISO 15189, and other ISO standard. Then Center for Accreditation of Veterinary Facilities, under which we offer accreditation for the veterinary service providers. So let's thoroughly go about our CHSC program, Center for Accreditation of Health and Social Care, under which we offer accreditation for the hospital, art and IO centers, ambulatory care, emergency department, clinic, home care, vision, dental, patient safety, WHO, stroke centers, dialysis, transition care, medical transport organizations, hair transplant, headache clinic, telehealth, hotel and homestays, green healthcare facility, EMT, and ISO 711 plus. So basically, 711 plus, we have developed this ISO standard 711. So this is a newly healthcare standard which implemented by ISO. So we have developed as a ISO 711. So CHSC program, we have international recognition. We become first accreditation body in India to achieve this QAI accreditation in less than 5 years of operations. We are we are the first and only accreditation body in India having two standard accredited by ISQA. Our CHSC program is recognized by Ministry of Health and Health Central Government Health Scheme, which is CGHS, for empanelment of private hospital, eye centers, dental centers, and imaging centers. So we are also an institutional member of International Society for Quality in Healthcare, ISQA. So this is a accreditation mark of QI. So though we do offer this accreditation mark, those hospital, those who complete QI accreditation process successfully. So this is a accreditation number of accreditation in 8 years. So total 188 healthcare service provider we have given accreditation. So we have geographical spread. We are not only limited to India. We have international presence. We having presence in Bahrain, Bangladesh, Ghana, Maldives, Mongolia, Morocco, Myanmar, Nepal, Qatar, Lebanon, Bhutan, and UAE. So these lab or healthcare facility got QA accreditation. So I would like to introduce our today's speaker. We have a very prominent faculty speaker. His name is Dr. S. Kumar Velu. He is a MD medicine from Armed Force Medical College, Pune, DM from Neurology, All India Institute of Medical Science, New Delhi. Presently, he is working with Aster Ramesh Hospital, Guntur, as a profession and head and lead consultant. His area of specialization is in stroke, neuroinfections, movement disorders, and he has got many achievements in his total journey, and also awarded as from MG Kinney Memorial Prize in Clinical Orthopedics, ANK Man and Gold Medal in Radiology, Certificate of Honor in Anatomy, Psychology, Biochemistry, and Pharmacology. He is a university topper in anatomy. Lieutenant Colonel K.K. Gupta Gold Medal, first in Advanced Medicine, Chief of Army Staff Commendation 2017, Fellow India College of Physicians, Indian Academy of Neurology, former Executive Committee member, Indian Stroke Association, Chief Assessor Stroke Accreditation with QI. So thank you. This is all about QI and today's speaker. So I welcome Dr. Kumar Velu, sir, to take further. Welcome, sir.
Hello. Thank you, Manish. Yeah, will you stop sharing? I'll share this slide.
Yes, I can see the screen.
Yeah. Is my presentation visible?
Yes, sir, it's visible.
Yeah. Good afternoon, everyone. I thank the QAI for having given me the opportunity to make a presentation on a topic which is close to my heart, that is stroke. Incidentally, this is the only clinician-driven accreditation program so far. Most of the time when we say accreditation, we always look into the quality department's work, not mine. I'm only a bystander. Whereas here it was driven by clinicians. Yeah. The stroke accreditation program has 10 chapters, having a total of 64 standards and 280 this criteria. We shall be concentrating on the continual quality improvement, patient assessment and care, patient rights and education, medication management, surgical care and safety, hygiene to some extent in this lecture. I presume governance and leadership, human resource management, and facility risk management will be covered if need be subsequently. Now, this is only slide on human resource management, which I thought is important, relevant to stroke, is that center has a documented system of competence, credentialing, and privileging of medical, nursing, and paramedical staff. What's essential, what it means is that we should have a defined, laid out program whereby the competence of the individual is assessed. Credentialing is given based on the qualification and what the individual asks for, and we privilege them accordingly to perform those things which the organization deems fit. Center has a documented system of maintaining personal files for all staff members. This is very essential so that we see that their personal information, qualifications, credential privileges, everything is documented and it is reviewed periodically on an annual basis. Now, coming to the last and most important, the center has a stroke program medical director, a new term. What we say is the center must have significant amount of training and expertise, knowledge required for stroke care and treating cerebrovascular disease. With this few things, we'll go to the next on information management system. We should have a documented policy and procedure should be there to meet the information needs of the center as evidenced in your policy. And the center should define what constitutes a medical record and maintains complete and accurate medical record for every patient. This is relevant. We'll go further in the medical record when we come to the other heads. Now, coming to the third standard, there's a documented policy and procedure regarding retention of time of records, data, and information. The center has a documented policy and procedure in place for maintaining confidentiality, integrity, and security of the records, data, and information, and a system for medical record audit, both closed and open. By closed, I mean after discharge, and open means as and when the patient is being treated. This is what I have said. Now we come to the CQ, continuous quality improvement. This will delve in detail as we go further. The management plans and leads a structured quality improvement and stay safety program for the, I'm sorry. Just a minute. PPT. Yeah. The leaders of the center should be accountable by service performance. The leaders and the management should get involved in the allocation of resources for improvement in quality and safety. And there should be a comprehensive quality improvement and patient safety program, which is developed, documented, and implemented. It should be maintained periodically. There is an interdisciplinary stroke committee, most important, interdisciplinary stroke committee, which comprises of the stroke program medical director, the nurse stroke coordinator, a quality representative, and or any other discipline representatives and the practitioner. The IDSC shall conduct quality and clinical reviews at regular intervals. The committee shall then in appropriate and corrective preventive actions are implemented and documented based on the identified gaps. Gaps means that which exists from the policy and what is on ground, and we try and correct it. Now, there's a designated individual for coordinating the quality improvement program and the safety program. Now, the designated person is, their name is communicated and coordinated amongst all the staff of the center through appropriate training mechanism. Regular audits should be conducted to ensure continuous compliance to quality and safety program. Now, this is again a very important for the clinical point of view. The center measures clinical and managerial structures, processes, and outcomes to promote quality improvement, namely data collection, including verification for measurements of clinical and managerial structure, processes, and outcomes are defined, and measures are used to determine areas for improvement, and results of measurements are communicated to all concerned. Now, coming down to the parameters for primary stroke center, the door to physician time is less than or equal to 10 minutes, and the door to stroke team arrival is less than or equal to 15 minutes. Door to CT-MRI initiation is 20, and the CT-MR interpretation is 30. Lab result TAT should be 30 minutes or less. Then connected contact like computer linkage, phone, etc. determined medically necessary by the AD physician within 20 minutes. Door to IV thrombolytic bolus, that is giving the time from the time that the patient arrives to the time you are picking the patient for giving the drug. It needs mandatory 75% compliance within 60 minutes, and within 60 minutes and 75% or more, they should be given the injection within 60. And in addition, one more rider, 50% or more should be within 45 minutes. That is the importance. Coming to advanced stroke center, the top parameters remain the same. In addition, the next thing, this is important. The percentage of ischemic stroke patients eligible for intravenous thrombolysis who receive it within the appropriate time window should be calculated. Ischemic stroke patients who develop symptomatic intracerebral hemorrhage within a period of 36 hours after the onset of treatment with the therapy should be calculated as attributable to the drug. For advanced stroke center, in addition to the above, we should see the peri-procedural complication rates after correction for various comorbidities following any intervention. The peri-procedural mortality rate for surgical and interventional procedures, the percentage of on-stroke TIA patients who have a deficit at the time of initial node, ED physician or neurology consultation node, for whom an NIHS score is documented. Important. Percentage of ischemic stroke patients eligible for intravenous thrombolysis who receive it within the appropriate time window and who receives within 60 minutes. And the next one is time from arrival to the start of initial imaging workup, as we said earlier, for all stroke victims who arrive within 24 hours of last known well. Median time from arrival to start of treatment for acute ischemic stroke patients undergoing an endovascular intervention. Now, this is symptomatic intracerebral hemorrhage, very important. I'm not dwelling on the definition of symptomatic intracerebral, but for our purpose, clinical deterioration of 4 or more points on the NIHS scale and brain image finding corresponding either with a parenchymal hematoma, subarachnoid hemorrhage, or intraventricular hemorrhage within 36 hours after the onset of treatment with that drug or mechanical endovascular reperfusion procedure. Either way, any procedure for that matter, be it aspiration or the stent retrieval. Percentage of patients undergoing carotid endarterectomy or carotid angioplasty or stenting having stroke or death within 30 days of the procedure, and percentage of patients undergoing intracranial angioplasty and or stenting for atherosclerotic disease having stroke or death within 30 days of the procedure, and percent of patients who are transferred from another hospital with documentation of time from the first call from the transferring hospital to the arrival at that center. Percentage of patients with stroke or death within 24 hours of diagnostic DSA, that is digital subtraction angiography. Percentage of patients who have a diagnosis of ischemic stroke who undergo EVD-related ventriculitis, that is infection. And percentage of ischemic stroke patients with a post-treatment reperfusion grade 2B or higher. in the vascular territory or beyond the target arterial occlusion at the end of treatment with intra-arterial thrombolytic therapy or mechanical endovascular reperfusion therapy. Intravascular thrombolytic therapy is more or less an exception nowadays. We don't use it routinely. Percentage of ischemic stroke patients with large vessel cerebral occlusion, that is ICA or ICA terminus, that is T occlusion, T lesions, MCA, M1 and M2, and basilar artery, who receive mechanical endovascular reperfusion therapy, that is the time of first pass or deployment of device within 120 minutes of hospital arrival, and achieve a TC2B or higher at the end of treatment. Center defines three managerial structure, process, and outcome. It also defines key indicators for safety structure, and they shall define the following key indicators, as I've said, namely hand hygiene, catheter-associated urinary tract infection, central line associated bloodstream infection, ventilator-associated pneumonia, and surgical site infection. Now, the next standard is robust incident reporting and monitoring mechanism. This is missing in most of the hospitals where we visit. But we should encourage incident reporting. In that, we know where we stand. Until unless you report a shortcoming, it will never be corrected. It will only be just hidden under the, pushed under the carpet. The time of reportable incidents and its management is defined and implemented. Sentinel events are identified, reported, analyzed, and corrective action taken. Various stakeholders are informed of the incidents, analysis results, and corrective and preventive actions are implemented. Now, coming to the next chapter, patient assessment and care. The important thing is it defines and displays its services. Very important. Most of the time where we go, we need to tell them that how do the common man know that your hospital has got capability to treat stroke? So until unless you display it. Services provided are displayed prominently for easy access of the user. The center has a documented registration and admission process, commonly most of us follow. Center provides appropriate emergency and ambulance services as and when asked for, where patients are appropriately assessed and reassessed and documented appropriately. There are pathways, protocol, and processes to rapidly identify, evaluate, and treat potential stroke patients. Staff in the emergency department shall demonstrate knowledge and understanding of the stroke protocol of the unit in place, including effective communication with the ambulance personnel, notification of the stroke team, and initiation of the stroke protocol. Staff in the emergency department shall demonstrate in the delivery of treatment in the form for IV thrombolysis, reversal of coagulopathies, a factor often missed, control and reduction of elevated intracranial pressure, control of seizures, and blood pressure management. The center shall assess and make treatment decisions as soon as possible of the arrival of the patient to the emergency department. It shall screen the patient for dysphagia, that is swallowing, before receiving any oral medications, food, or fluids. They should also test for blood glucose levels before thrombolytic agent as eligibility is determined. A level less than 50 or more than 400 is a relative contraindication before you correct it back to normal. The patient shall be assessed by a qualified nurse or physician member of the acute stroke team. IV thrombolytic agent administered within 4.5 hours of last known well. Here we have made the assessors can have a leeway in that. Depending on, if it is a wake-up stroke, you can go up to 6 hours, depending on criteria already laid out and displayed, and which has been reflected in the guidelines, AHA, ASA, as well as the European stroke guidelines. And with the latest addition of MR perfusion imaging into the clinical realm, we can go up to 9 hours, provided the diffusion perfusion mismatch persists. Now, there is recognition, assessment, and management of complications of acute stroke, and a process for notification of deterioration to medical staff and others. The center shall document the reason in the event of an eligible patient with ischemic stroke as to why the patient was not given IV thrombolytic therapy. Patient should be assessed for endovascular treatment options, whether receiving thrombolytic agent or not. Even if they are not a candidate for thrombolysis, one should always consider endovascular treatment if they have a large vessel occlusion. Specified time frames, as I mentioned earlier, should be addressed and as in the stroke protocol. We have to publish and maintain a current and complete call schedule. This is again missing. When we go on visit, we have to keep it, the call register, so that it is accordingly monitored, whether the calls were sent in time and what was the response time of the concerned team member to arrive. The emergency department, this is what I have said. Emergency department practitioners will have access to appropriately qualified personnel for consultation regarding the use of IV thrombolytic therapy when obtained from a physician competent and privileged by the unit in the diagnosis and treatment of ischemic stroke. ED practitioners can demonstrate safe use of thrombolytic agent. By that we mean every ED practitioner should be capable of administering the thrombolytic agent. Ambulance services should be available as per the scope display, and they should meet regulatory statutory norms. There should be a written plan for transporting and receiving patients with stroke. The center shall have a system of notification when a patient with suspected stroke is being transported to the center in order to activate the stroke team. The center defines the circumstance in which it is not able to accept patients as to when we cannot receive the patient. This important PSC 4, we should have a designated stroke team with trained personnel. All members should have the current job description, again missing in most of the centers when we visit, available, that contains the experience, educational and physical requirements, and performance expectations for the role in the stroke team. Annual performance evaluation should be done related to stroke-related activities. The center shall define the criteria, qualifications, roles, and responsibilities through plan, policy, or procedure required for designation of the personnel. The stroke team is available 24/7. The stroke team shall respond to stroke alerts in the ED. They may also respond to inpatient stroke alerts as designated. Members of the stroke team will receive initial orientation and ongoing education. The center should provide appropriate and adequate laboratory and imaging services. This is what is this thing, like CT is mandatory for a primary stroke center, while an in-house MRI is mandatory for an advanced stroke center. Now, PAC 6, patients in the center are appropriately assessed. This should be properly done periodically and at regular intervals. There should be an assessment which should be documented. And what is important and missing is this assessment should be authenticated appropriately by a staff with their full designation. Assessment results in formulation, modification of appropriate care monitoring plan can be done, but however the same need to be documented. Coming to the next. Center ensures uniform care and continuity of patient care. So there should be guideline, procedure should be there. How to treat patients with stroke as per best practices and the appropriate laws and regulations which govern in the place of our practice. The care plan for every patient is individualized and independent on their needs of assessment and reassessment by the multidisciplinary approach. The organization adapts evidence-based clinical practice and clinical protocols to guide uniform patient care. Clinical care pathways are developed, consistently followed across all settings of stroke, and reviewed periodically. Resuscitation services should be available throughout the center with properly equipped medication, stocked medicines, and trained staff. Events and treatment provided during resuscitation events are recorded, and resultant data is analyzed by multidisciplinary committee to identify opportunities for improvements. If once you identify the scope for improvement, they should be implemented. And there should be a periodic monitoring whether they are being implemented or not. Next, it provides nursing care in accordance with standard protocols, practices, and current evidences. This is self-explanatory. We'll not dwell further. And that there should be detailed neurologic assessments and scales by the nurses also. Nursing care of patients receiving thrombolytic agent there's a well laid down protocol which should be adhered to. Management post thrombolysis care and other invasive neurosurgical patients. And blood pressure management is very essential, both pre, intra, and post procedure. Intensive care services are provided in an appropriate manner as per the requirement of the patient. Infection control processes are implemented in accordance with the current practice and evidence. Nutritional requirements are assessed and addressed appropriately. There should be documented procedures define implementation of nutritional screening for all patients, procedure for provision of diet, patient diet, including therapeutic diet, are implemented. Now coming to rehab, it should be consistent, appropriate. They should be aligned with the scope, and services should be provided in a safe, consistent, and collaborative manner. Care is guided by functional assessment and periodic reassessments which are done and documented. The center shall require physical, occupational, and speech therapists to be readily available 7 days a week for patient assessment and therapy during patient hospitalization. Assessment shall be completed within 24 hours of admission when feasible. Physiotherapists must have adequate knowledge regarding neurology, stroke care, care coordination, levels of rehabilitation. Levels can vary depending on the deficit the individual suffers from, including gait training and which should be proper, and limb physiotherapy. Physiotherapists must have adequate knowledge regarding neurology and stroke care, care coordination, and levels of rehabilitation. Our aim is train for maximum recovery, prevent and treat comorbid conditions, and enhance the quality of life. They should document the pre-morbid modified Rankin scale score, modified Rankin score at discharge, and at 90 days. End of life and palliative care are provided appropriately as per documented procedures based on attendance requirement. A documented discharge process exists and a discharge summary is provided to all. This is based on the MCI guideline. The center plans a discharge process in consultation with the patient and our family. There should be a documented policy and procedure for patients leaving against medical advice. A word of caution when we discharge patients against medical advice is that you are duty bound to provide post-discharge treatment advice. You cannot say, no, he is going against medical, I cannot document. That's not acceptable in legal parlance. Discharge treatment summary contains the patient's name, unique identification number, treating physician's name, qualification, and registration number, date of admission and date of discharge, duly signed. Very important. Duly signed by the appropriate qualified medical professional. Most of the time, these parameters are missing when we go on a visit. Discharge treatment summary contains reasons for admission, significant findings, and diagnosis and patient's condition at the time of discharge. What happens is the investigations is left out in most of the hospitals in the discharge summary, which is against the MCI norms. And follow-up advice, medication and other instructions in a manner that is understood by the patient and family. Somebody should make an effort to explain what they are supposed to do after discharge, and when to obtain emergency care and whom to approach. And in case of death, patient records include death summary, The center shall document type and usage of telemedicine technologies available. The center shall define the need of required equipment and technologies for telemedicine, and the practice shall follow regulations. This has become legalized since 25th March 2020 during the COVID onslaught. And there has been even WhatsApp consultations are permitted provided they go through a proper methodology of the patient requesting a consultation, and certain minimum parameters should be asked for. Patient should be seen. Necessary examination based to the extent feasible should be carried out on visual inspection and documented appropriately. And whosoever is providing medical this thing, they should have the requisite training and expertise as to how to carry out a teleconsultation. It should be available as soon as possible, preferably within 20 minutes of seeking such services by the emergency physician in order to meet the 60-minute target for door-to-needle time. Next chapter, patient rights and education, PRE. Very important. The center protects the rights of patients and informs the patients about their responsibilities while receiving care. It should be documented and displayed bilingually wherever they are, in the mother tongue as well as in English, as far as possible and prominently. Violation of rights is reported and action taken is also documented. Next standard is it identifies and documents the right of patients supporting individual beliefs and values. The patient rights including privacy while receiving care, dignity and respect while receiving care, and confidentiality of information, personal safety and security. Informed consent. Most of the time what happens is this is one thing missing in most of the places. You just ask the relative, just sign here, that's all, on the dotted line, but without explaining the procedure, what is the problem, what are the beneficial effects, what are the negative effects that can happen to the patient. And thereafter the document and the signature should be appropriately witnessed, apart from the physician who deal with the requirement. Patient has every right to refuse treatment, and there should be an expected cost of treatment should be displayed and informed. And whenever they ask for, you must be prepared to give a duplicate copy of the medical records. They have every right to complain, and how to voice a complaint should be explained. And they should have information on his treatment and healthcare needs should be discussed and disclosed at regular intervals. Any special preferences, spiritual and cultural needs should be honored and adhered to. Patient rights include to seek an additional opinion regarding clinical care. It is their right to ask for a second opinion if they want to. The center educates the patient and family to make informed decisions and their involvement in care planning. It's always better to discuss the patients and the family, what is happening and what are we planning to do, and keep them involved in the patient management so that they are concerned and consider and they feel that they are being into the part of treatment team. Patients and families are explained about the medicines, nutrition, and use of medical equipment. Like when we intubate a patient, for instance, we always should explain to them what is the need for intubation and how long the patient may require and what is the likely cause will be explained by the administration. Now, the patient and the family members are explained about the possible complications. This should be explained. Like when we do thrombolysis, for instance, the two major complications that we are worried about in thrombolysis is one is bleeding. Symptomatic intracerebral hemorrhage is the worst that we can look at. We don't bother about minor bleed, which happens with gums and other things, which are controllable with local measures. And two, anaphylactic shock. You must be very cautious and careful when this is there, and be observant as to the cause. Like if there is a sudden respiratory distress, bloating of the face, swelling, unwanted swelling like angioneurotic edema, and urticaria, you must rise up to the occasion and treat it as a real emergency, lest you may lose the patient due to the complication. The patient and the family members are informed about the results of diagnostic tests and the diagnosis. Like, it's always better to brief them after the imaging is done as to what has transpired in the images. Center documents a procedure to obtain informed consent. Yes, it has to be documented. It's always better to clearly draft it down so that you don't miss out in a hurry as to what is this thing. And always explain to the attendant, whosoever is signing the informed consent, as to the kindly go through the paper, let us go through it, and in case if they have queries, they are welcome to discuss. The procedure describes who can give consent when a patient is incapable of independent of decision making. This is an important thing. Like, at times a patient can be brought by an onlooker to the hospital, and the patient condition may warrant intervention, which may not be in a position to wait. In such case, it's always better, if need be, take a video consultation with the attendant who's supposed to be decision making on a video consultation, and take their consent and document it accordingly, so that you are not pulled up later that you have treated my patient without my consent. Okay? And whosoever is doing the procedure should take the consent. You detail it not to your your resident or medical officer. No, you should be allowed. Center has a documented feedback, compliment and complaint. Both should be documented. I feel that complaint should be documented much more, so that you have a scope for improving your processes. And it should be clearly explained to them as to how to receive a complaint, investigate and resolve it in a timely manner. And patients and their family should be made aware of a feedback giving mechanism. Center uses results of investigations to make improvements. Medication management and safety. There should be a documented policy and procedure for management of medication. The center develops a drug formulary based on the needs. In our case, stroke-related drug formulary, where there are certain drugs which can never be stocked out, and there are certain drugs which have to be high demand items, and some drugs they can have some possible leeway. And it should be reviewed and updated at least annually. Now, storage should be appropriately done, and it should be documented and followed appropriately. That should be as per manufacturer's recommendation. Lookalike and sound-alike medications are identified and stored physically apart from each other. Emergency medicines are identified and readily available for use in patient care areas. There's a documented policy and procedure for prescription of medication. There should be a clear-cut guideline in consonance with law, good practices and guidelines for rational prescription of medications. Who can prescribe? Only qualified healthcare providers according to their license. Center defines and implements minimum requirements for medication prescription as per law. Now, there's a documented policy and procedure exists for safe dispensing of medications. Like, you cannot say to a nurse, inka thrombolytic drug, tenecteplase evendi. You just tell him, just give tenecteplase, and he cannot afford to walk off. You should be there, explain to them how to dilute the drug, how much to administer, because the calculation is yours. And stand there when it is being done, so that there is no mistake taking place in the way in which it is mixed and taken and admitted appropriately. And time it as to the minute. A documented policy and procedure exists for safe administration of medication. This is what I have said. And it is verified from the order and physically inspected prior to administration. Don't go by the envelope alone. You have to see the drug container, open it and see the label, see the expiry date before you start using it. There's a documented policy and procedure for use of narcotic drugs and psychotropic substances. There should be clear-cut guideline, without which you can be in thick problem with the drug controlling. And administration of narcotic drugs and psychotropic substances documented, and it should be properly signed. Storage is equally important for narcotics. Now, medical devices and implantable processes, there should be appropriately documented and done. In a country like India, where we do reuse one-time use appliances, it's permitted in certain settings, provided your policy states so, and you label your reuse policy accordingly and documented in the patient document also. That's important. Documented procedure exists for the performance of various procedures and surgery, that is surgical safety list. And what is important is you should have a procedure for surgical care and a structured safety program. And anesthesia and sedation, that conscious sedation definition should be there, and anesthetic administration should be done appropriately with the explanation to the patient. Last chapter, hygiene and infection control. Center has a documented infection prevention and control policy. It should be there clear cut as per the guidelines. And there's a comprehensive infection prevention and control program should be existent, and it should be monitored by a multidisciplinary infection control committee. The importance is hand hygiene practice, the 5 movements of hand hygiene, they say, and we should practice it regularly. And the team, the medical officer and the medical personnel should set an example to the subordinates. And if the medical officer is not doing it, the nurse should be clear. Be polite, but ensure that your medical officer washes the hands, maintain hand hygiene as per standard guideline. Okay, so this will go a long way in prevention of infections, and appropriately training should be exhibited. Infection prevention and control program includes clinical services, important. And it includes ancillary services also, like in the laboratory, how they handle the body fluids, that's important. And in the laundry, the linen, soil linen usage, and kitchen sanitation is mandatory. And the staff there, how are they protected against communicable diseases which are laid down? Plus, all the places like airflow, ventilation, humidity control should be maintained as per guidelines in places, especially like the intensive care unit and the operation theater, because these are the places where the patient is most vulnerable and exposed to the risk of infection. And there should be a clear-cut process of cleaning, disinfection, sterilization practices across the center. And there should be a documented policy on biomedical waste segregation and disposal in accordance with statutory regulations. This should be mandated and should be done. And there is another place where we find a lag in the hospitals where they denigrate the responsibility to the least lowermost staff who may not be really educated. And waste segregation should be performed at the source rather than at the common disposal area. And personal protective equipment should be available appropriately while handling the waste. And collection of medical and non-medical waste in accordance to safety regulation should be monitored. And occupational health requirements relating to the infection control for staff handling these things should also be addressed with giving them proper protective equipment and how to dispose them of after use. That's important. Staff should be approximately vaccinated and documented accordingly. Post-exposure prophylaxis, especially following a pinprick. That's important. It happens often. And pinprick usually happens to the class 4 servant who is picking up the waste from the wards, especially in intensive care setting and the emergency department. So when we dispose them correctly, when the nursing staff disposes the waste correctly, the chance of needle prick becomes very less. That's important. Center implements monitoring and surveillance of infection prevention and control on a regular basis, and the HAI team should be accordingly equipped to implement the same and bring it to the notice of the management if there is a shortcoming. These are the quality indicators that we capture on a monthly basis that I said about in the mandatory requirement inside. This is all documented. Next is the timing, as we have said earlier. Now, these are the incidents of stroke patients and acute stroke. This I have enumerated in the requirement earlier. Okay. and the standards or benchmarks are displayed. Now, with this, I come to the end of my presentation. This is what is important is if we adhere to all the standards that are being displayed in the Quality Accreditation Institute program for stroke management, we'll definitely go a long way in alleviating the sufferings of the poor stroke victims and the pocket of the family as well. With this, I've completed my presentation. Thank you.
Thank Thank you so much, sir, for your wonderful presentation. So I request Ms. Chandni to go ahead with the QA accreditation process. Then later on, we'll take a QA session. Uh, Welcome, Chandni. Over to you.
Yeah, apologies. Good evening, everyone. Hello, Melissa.
Glad.
Yeah. So please let me know, everyone, when my screen is visible.
Yes, it's visible.
Yeah, so I'll be explaining the process of the accreditation for the Stroke Center program. Okay, so first, the organization is given an application package that consists of several documents, including a self-assessment toolkit, the application form, SAT documents, and the fees. So the organizations do a self-assessment of themselves to see whether they are eligible for the stroke center accreditation or not. Depends on the eligibility criteria, different for both primary and advanced stroke center. Then after the self-assessment toolkit, the organization they have to implement the QAI accreditation standard for the stroke center for 2 months and have to provide the documentations like application form, SAT, and the fees at the time of the application. Then the registration and the review and acknowledgement of the application is done by the QAI Secretariat upon the receiving of these documents. And there's an option for the organizations that they could just perform a pre-assessment that could be online, remote, or hybrid, followed by on-site remote hybrid assessment that the dates are flexible. That depends on the organization as well as the assessors on the availability. Then there is a report review of the report generated after the assessment that includes the scoring and the non-compliances that were raised during the assessment. And if the organization meets the score and submits the corrective action for the non-compliances, then the secretariat takes it to the accreditation committee for the validation of scores and the acceptance of the corrective actions, followed by the issuance of the accreditation certificate, which has a validity of 3 years. And later, there is an on-site remote or hybrid surveillance assessment after 15 to 18 months of accreditation. And the organizations which wish to renew the applications have to apply 6 months before the expiry of the application. Okay, so what are the benefits of the accreditation? For the patient, it is an enhanced safety and trust that assures that the procedures are conducted well. They are qualified professionals in the organization, there is transparency and right, and continuity of the care. For healthcare facilities, it is that they are committing quality patient care, and the community is assured about the quality of services and better health outcomes, and they function in a transparent and ethical manner. They also act as a potential mechanism of risk management, and it is a process to stimulate the continuous improvement of the organization and a mechanism of self-regulation. And for the healthcare staff, it provides opportunity for all the level of the staff in their professional development and higher staff satisfaction because of the good working environment, leadership opportunities, and ownership of the process. And the documentation is done in place, the procedures are in place, so it also helps in building staff confidence and to deliver proper care. And for the third party, it helps in objective system of evaluations and empanelment by the third parties like insurance companies, other payers, government, etc. And it helps in access to reliable and documented information on facilities, infrastructure, services, and level of care. Now, the objective of these standards is to provide a framework for quality assurance and quality improvement that focus on patient safety and quality of patient care. They are standards for quality and safety that organization must achieve, and they are also revised periodically. That raises the bar. And it all because we as QAI are internationally recognized organizations, it also helps the organizations also to achieve international recognition. The QAI standards for primary and advanced stroke center are developed in collaboration with the Indian Stroke Associations that consist of 10 chapters, 64 standards, and 280 criteria, as explained by Dr. Kumar Velu. And QAI offers two type of accreditation programs for the stroke center. One is a stroke center accreditation program, that is the SC, and one is the advanced stroke center. Now, they might vary in the following healthcare settings. It can be for academic or teaching hospital, district public hospital, private or a corporate hospital, and a standalone just a stroke center also. Okay, so the standards framework are as follows. There is a chapters. Chapters are divided into standards and followed by the criteria. For example, if there is a governance and leadership chapter, they have standards like GAL 1, 2, 3, and there are criteria like GAL 1A, GAL 1B, etc. So QAI has some major organizations in its stroke center program. For example, we have Lalita Super Speciality Hospital, Max Hospital, Synthil, Dr. Vanchulingam, Baby Memorial, Dr. Ramesh Cardiac, Mazumdar Shah, Apollo BGS, Maitra, Apollo Hospital International Limited, Sidus, First European, Sims Hospital, Ruby Hall Clinic, Ashoka Medicover, Calcutta Medical Research Institute, Ukar Hospital, KIMS Hospital, NM Irani, Jeet Kupuswamy, KMC, Sri Ramakrishna, Ukar Hospital, CMC Vellore, and Ranipet, Paras Hospital, KG Hospital, what is Shalimar Bagh, Shalby, Avitis, and Lata Super Speciality. And primary also, we're talking about the stroke center program. We have 5 major organizations with us. Now, QA also offers support in trainings on accreditation standards, the DIVE program, internal audit, and self-assessment toolkit. Thank you.
Thank you, Ms. Chandni, for hello. Yeah, thank you, Ms. Chandni, for a briefly give introduction of QA accreditation process. So now we are open for your query and doubts. If you people have query and doubts, you may unmute yourself and ask from Dr. Kumar Velu sir or from QI accreditation officer. So you may unmute yourself, or if anyone having doubts, you may drop into the chat box also. For future query, I drop our email ID, our contact number, our website domain name. I drop into the chat box also. So you may contact us either through email or through call. Okay. So I think no one having any query and doubts. So thank you, sir. Thank you so much for your wonderful session.
Thank
And
you.
thanks for the participant for your active participation.
Thank you. Thank
Thank
you.
you, sir. Thank you so much.
Thank you, Manish. Thank you, Chandni. Thanks.
Thank you, sir.